Good afternoon, everyone. Thank you so much for coming to this educational session, Case-Based Clinical Approach to ER-Positive Metastatic Breast Cancer in honor of Dr. V. Craig Jordan. Bill Gradishar is going to do a little memorial in a moment for him. On behalf of my co-moderator, Bill Gradishar, we're really happy to be here today with you. And I'd like to thank Dr. Oliphant, Lipsyc-Sharf, Vasan, Stover, and Beumer? Beumer. Okay. It's going to be a really interactive, great day. So, and there's going to be polling, so we'd like you to be interactive and send us your questions as well. Here are our relevant disclosures. And, oops, they didn't put in all the others, but they should be available if you want to look them up, and I think several people had none. So I'm going to pass this now to, oh, here, they did it in the wrong order. Oh, gosh. Okay. I'm just going to have it here.
Go ahead. We know what's coming.
It's not, yeah, go ahead.
Okay, so thank you, and it's a pleasure to be part of this symposium. And
there's no picture. They don't have. We have another deck.
Yes,
yeah,
please.
that'd be great.
Okay, let's try this again. So with that pregnant pause, we're going to go to the appropriate deck. But what I'd like to just start out saying is this session is in memory of Craig Jordan. And for any of those who have been at this meeting for a number of years or been in the field for a number of years, I think you're familiar with Craig and his contributions. Craig called many different academic institutions his home over his career, his last one being at MD Anderson. I came to know him more than 20 years ago when he was at Northwestern for a period of his career. And his contributions are appropriate for this particular session because what he really investigated over the course of his career was insights into estrogen receptor biology, and then also understanding how you can make that clinically relevant. He was very integral in the development of tamoxifen, both as a therapeutic for breast cancer, early and late stage, and subsequently actually developing that along with others as a preventive agent, and that led to other drugs like raloxifene. And his insights in the lab also provided some understanding of mechanisms of resistance, which we're now, of course, addressing with the slew of new drugs that are coming along, some of which we'll probably talk about today. So his contributions are legion. His progeny, his academic progeny, now populate institutions around the world, including pharma, academic leadership positions in this country, as well as others, as well as clinicians who interacted with him over the course of his career, who are now focused in breast cancer and caring for patients. I think, over the course of Craig's career, he probably won just about every award there is in medicine, and that includes the Susan B. Komen Award for Basic Science here several years ago, as well as awards given by other countries around the world. I think what he would be most touched by is actually being recognized here, because what he always wanted to do was have some impact on what translates into taking care of patients and what physicians and clinicians have available to treat patients. So my guess is, even though we won't see him at the microphone today, he'll be there in spirit, because typical of Craig, he was a force of nature. If you were in a room, even if you didn't know who he was, if there were 1,000 people, there'd be a loud noise from one part of the room. That's where Craig was, and he usually had a lot of people around him. So I think he would be touched, again, knowing that this symposium, which is clinical in nature, is given in his memory. So with that, I'll turn it back to you.
Thank you. That was beautiful. Before we get started on cases, I'm going to ask Michael to give us a little bit of background in terms of how we evaluate ER-positive breast cancer preclinically to try and understand mechanisms of resistance.
Awesome. Thank you so much. And thank you for the opportunity to speak to you guys from a kind of basic research perspective. So I just wanted to quickly give some background on some of the models that we're really leveraging to try to understand things like tumor progression and drug resistance, and particularly in the ER-positive space. And so, as many people have talked about, Christina talked about in her talk as well, patient-derived organoid models have really been in the last few years, even a little bit longer, have really been a critical tool that we're now trying to leverage to better understand these mechanisms and how we could potentially develop therapeutic strategies. For ER-positive, however, this has been a little bit of a challenge, and it's mainly led to the use of 2D cell line models for most of the studies. Now, these 2D cell line models have been absolutely, critical for understanding ER-positive tumor progression and drug resistance, and they led to a lot of different discoveries, obviously. But for ER-positive 3D organoid models, this has been very, very difficult. And I've listed a few reasons here, but there are multiple other reasons. But for instance, they really suffer from a low establishment rate. And then if you are able to establish them, they actually they grow very, very slow. So it's really hard to do kind of things in an efficient manner. And then two critical things that I think are important to point out is that when you do establish these models, these 3D organoid models for ER-positive breast cancer, they generally suffer from a loss of ER expression over time. And then moreover, they usually lack response to endocrine therapies, which is obviously very important in this context. And as I mentioned, there has been a lot of efforts to not only establish 3D organoid models for all breast cancer subtypes, but particularly in ER-positive. So I'm just highlighting a couple here. So Hans Cleaver's group really had a seminal work where they established a living biobank of patient-derived organoid models. More recently, Alana Whelm's group has also established more of a PDX-centric organoid biobank. And then more recently, this is work from the Muthuswamy lab and the Brugge lab, which I'm a part of, where we really focused on ER-positive patient-derived organoid models. And we really focused on a lot of things that allow for the support of not only the establishment, but the robust growth of these organoid models. And we've termed this breast tumor organoid media, or BTOM. I've listed some of the critical factors of this media. And we really are excited about leveraging this now in the ER-positive breast cancer space. And so with that, I'd be happy to discuss this in more detail after the discussion, but just wanted to set the tone from the basic research side and using patient-derived organoid models.
Thank you. So much progress has taken place, and just in the last 5 years or so in the establishment of ER-positive organoids, so really great to have you here. So now we're going to turn to Dr. Lipsyc-Sharf, who's going to present our first case.
Thank you. So this is a case of a 38-year-old premenopausal woman who was previously healthy, and she presented to her gynecologist with a palpable lump, and upon biopsy was found to have a grade 2 ER-positive, 90%, PR-positive 10%, HER2 low with IHC2 plus FISH negative, 3 centimeters, clinically node positive, invasive ductal carcinoma. And she underwent lumpectomy and sentinel lymph node biopsy, and on surgical pathology was staged as a T2N1A. She had an Oncotype score performed on her tumor, which was 28, and she received adjuvant docetaxel cyclophosphamide and radiation. Also in the adjuvant setting for systemic therapy, she was treated with Lupron and tamoxifen. She had initially tried letrozole and exemestane and had significant arthralgias despite pharmacologic and conservative interventions, and she received Lupron and tamoxifen for 2.5 years. And at that point developed new persistent back pain. An MRI was performed and showed a sclerotic L2 lesion, and a PET CT was subsequently performed showing a right rib lesion and 2 liver lesions.
Okay, so I think we have a polling question, but I'm not sure how this works. So is there a QR?
They have it.
Yeah. So the question?
Excellent. So the question is, which diagnostic test or tests would you perform? A, tissue biopsy. B, tissue biopsy with next-generation sequencing. C, liquid biopsy that is tumor-informed. Or D, liquid biopsy that is plasma only.
Go vote. There we go. So there's the QR code. Now I know for all the other questions. Thanks for bearing with me. I'll give you a few minutes. Yeah. All right. Well, I'm really interested in seeing how this is evolving. And Dan, I'm going to pass it over to you to talk to us a little bit about this. And then I want to poll our panel here and hear how you would answer that question.
Sure. So yeah, it looked like that the overwhelming response was tissue biopsy with next generation sequencing, and we know that there's still value at the time of metastatic diagnosis of obtaining tissue biopsy, confirming that it's malignant, confirming that it's breast cancer, confirming receptors, which we know that there's subtype switching in a decent proportion of patients, particularly as you go on in therapy, but even at the time of metastatic diagnosis. We also know that there's the potential to identify genomic alterations and a growing list of paired potential FDA-approved therapies, highlighting a few of those that are frequent in the somatic setting for breast cancer. And we know that certain of these alterations are present early on in the development of breast cancer, particularly PI3 kinase mutations. And we also know that inavolisib has also been approved in the AKT pathway alterations as well. And I think there's great excitement about liquid biopsy. I don't know if there's many that are more excited about liquid biopsy than me, but I think there's a lot of potential for liquid biopsy across the clinical spectrum, in particular in the metastatic setting. But importantly, I think having that tissue so we can confirm the diagnosis, confirm the receptor status, and I think it's reasonable to get genomic testing at this time because we will at least uncover whether some of those truncal mutations like PI3 kinase may be present at metastatic diagnosis.
So let me ask you, Bill, are you, let's assume we would all biopsy to establish she has metastatic disease, but would you go so far as to do next-gen sequencing in this setting at the first line, or would you wait until progression had happened?
Well, I think as we hear, this too is evolving. We might have said fairly emphatically, well, we don't need the information for first recurrence, but now we have therapeutic that potentially in certain patients could be used in that setting depending on the abnormality present. And I'm talking about inavolisib. So, again, you might be more inclined to be doing it earlier than you had been 6 months ago.
Right. Neil, what about you in your practice?
Yeah, I think because this is such a fast-moving field, I think that a couple years ago we were thinking about this more for each individual patient, trying to tailor these when we deploy these techniques. I think now we're moving more towards perhaps a one-size-fits-all approach where we're really getting all of this information in the in the first-line setting, and certainly talking to patients. I think anecdotally, patients want this information as well, right from the start of their metastatic treatment journey, and so. But again, this is also a very fast-moving field, and I think that with the advances in liquid biopsies and how we get enormous amounts of information from that, it's really enabling us to really make sure we're treating patients the best way possible.
Okay, great. Let's move on to this case and hear a little bit more, and we'll have another polling.
So a tissue biopsy of the liver lesion showed a grade 2 ER-positive, PR-negative, HER2-low invasive ductal carcinoma, and tissue next-generation sequencing did not reveal any mutations in PIK3CA, AKT, PTEN, ESR1, BRCA1 and 2, or ERBB2. And she is treated with anastrozole and ribociclib.
Does everybody agree with this first-line treatment? If she was, let's say, had some liver function abnormalities and a lot of pain in the bone, would anybody do chemotherapy? Dan, what about you?
So, again, speaking to the rapidly changing field, I think even a couple of years ago, for high-volume disease, that was a consideration. But given the sort of growing amount of data that we have that first-line AI plus CDK4/6 inhibitor can have very effective disease control and high response rates, even in patients with a high disease burden. I rarely give first-line chemotherapy for estrogen-positive, HER2-negative metastatic breast cancer anymore.
Okay, thank you. So here's another polling question, and this time I'll do it right. How would you monitor her response to treatment? Serial imaging and protein-based tumor markers, serial imaging and ctDNA, serial imaging and protein-based tumor markers, and ctDNA. All right, we're not seeing the result. There we go. Okay, interesting. Bill, what do you think of those results there?
Well, I don't think we're going to give up serial imaging at this point. That's probably still what we would view as conventional, but I think we're depending more and more on, looking at ctDNA as a guide. I think there's still debate about what the utility of things like CEA, CA19, things like that. I welcome others' opinion about that.
Yeah, the circulating tumor DNA is a way to measure, pick up progression early is becoming more and more popular, especially as these assays they seem to be going direct to consumer almost in terms of their availability. Are you doing that in your own practice, Neil?
Yeah, so I am not, but I do think, as you said, there's this growing body of evidence. I think we're seeing this in a lot of targeted therapy trials where the ctDNA clearance within the first cycle of therapy is an excellent prognostic marker for long-term disease control. So I think this is, and we have trials like PATA-1 and other trials using these as predictive biomarkers for treatment switches. So I think that this is still a growing area of inquiry.
I completely agree. And Amy, I want your input here. First, I'm going to have Dan go through the next few slides, but I really want a patient perspective on this because this is a super hot topic. Awesome. All right, Dan.
Thanks. Yeah. So, I think we've already heard about different liquid biopsy approaches. There's a great ctDNA session earlier, and we know that liquid biopsy can encompass circulating tumor DNA, protein, tumor markers, which have been around quite a bit longer, as well as circulating tumor cells. Most of the data we have are primarily around circulating tumor DNA and tumor markers in the clinical setting. And we know that tumor markers may not necessarily track with patients' cancer. Sometimes they do, and they can be useful. Sometimes they don't, but they also don't reveal any additional mutation data. Circulating tumor DNA also appears to be associated with outcome and can detect tumor mutations, which might inform us about tumor biology or guide therapy. But there's a huge heterogeneity in how much ctDNA is present. Many patients have very low or nearly undetectable by sort of standard commercial assays in the metastatic setting. Go to the next slide. As Neil mentioned, there is great interest in whether we can use ctDNA to monitor metastatic breast cancer, and a lot of that has stemmed from the PATA-1 trial, where patients who had a detected ESR1 mutation were randomized to either switch therapy to fulvestrant plus palbociclib or continue therapy with AI plus palbociclib, and then were followed. We could see that those patients who switched therapy had a longer progression-free survival. You can go to the next animation. And we can see those numbers there, that there was a significant hazard ratio, but monitoring ctDNA dynamics is not standard yet, but I think it's intriguing. And I think once we have more definitive studies that show that making that switch and in what context that we do that, then I think that that's the setting where it will be used more widely. I agree with Neil that I often will turn to ctDNA sometimes as a tiebreaker, if I have indeterminate imaging, but I don't routinely follow ctDNA, for example, tumor fraction levels on all of my patients in this setting.
Yeah, I would agree with you. I'm concerned that it's too much information since we don't know that switching early improves survival. But Amy, from a patient perspective, how are you feeling about these very rapidly evolving data sets as well as the rapid availability of these assays?
I think there is, I'm definitely one of the people who likes to have a lot of information, and I think a lot of patients do like to have a lot of information. So, oh, that works. And I like the idea of using it as a tiebreaker. I think that's important. We know that tumor markers, they work for some people, they don't work for other people. So having the ctDNA as an alternative, or better yet, as something that's even better to help us monitor treatment is something that we're very interested in. And I think there is a lot of, I would say, direct-to-consumer of marketing here as well. So having the information and having oncologists be able to communicate that information to us is really important.
Thank you. So Marla, we have an update on this case.
Yes. So after 3 years on anastrozole and ribociclib, she developed new mixed lytic and sclerotic lesions in her T10 to T11 vertebrae and multiple new liver lesions. At that point, a liquid biopsy was performed and an RB1 mutation was identified, and she was switched to fulvestrant and everolimus.
And how did she do? Is she still on it?
She is doing well. She is still on that.
Very good.
So I'll start with one of the questions that came in, and I'll direct this one to Dan, and that is, I think we sort of accept that in order to confirm a diagnosis of metastatic disease, we're going to want a piece of tissue. But can you comment on the overlap regarding the information provided by ctDNA versus a tissue biopsy? Are they mutually exclusive? Are they additive?
Yeah, so that's a great question of whether liquid biopsy and tissue are exactly overlapping. I think Heather Parsons showed this really nicely. There is strong overlap, particularly of clonal mutations, 80 to 90%, or maybe even higher are overlapping. But we know that ctDNA may capture more as a sink of multiple metastatic sites, but may also be limited by the amount of tumor-derived DNA. So, I do, at the time of progression after first-line therapy, think about a liquid biopsy. It's patient-centered, it's minimally invasive, and hope that we can get the detection sensitivity necessary to make a call of whether they have a targetable mutation. So I definitely feel comfortable not re-biopsying after the first line and using liquid biopsy in that setting to try and make that second treatment switch decision.
And one other question before we move on. There were several questions regarding cost as well as what tests. We have many platforms, many vendors in a sense that are providing this kind of tool. Neil, any thoughts or any pushback on getting this serially that you've experienced?
Yeah, that's a great question. I have not had immense pushback, but I will say these seem to be anecdotal cases. It seems to be just one, 2, 3 patients I'm thinking of, and I think this is where real-world evidence could be very helpful, even crowdsourcing information from oncologists at conferences like this.
Yeah, and Amy, I guess you would have a better sense from the patient community whether this is an issue that they're confronting.
So far, it seems like companies have been very good about making sure that the cost is covered in some way if insurance does not cover it. I have not heard of it being a problem or not being covered for patients, but that's just my experience.
And Dan, any preference on the platform?
Yeah, I think that the great thing right now is that there's a lot of great commercial assays that are available. Each one has some strengths and limitations, but all of them are evolving. And I think the exciting thing with competition is that it sort of pushes the bar up, both in terms of quantity of genes assessed, additional things like methylation that are being utilized, and then hopefully cost for our patient perspective.
Okay. Well, let's move on to the second case, and I'm going to direct this to Neil. Yeah, sorry.
All right, so this...
Back one. Okay. The case sort of disappeared.
It did.
Okay, well,
Why don't we
There it is. All right.
So this is a 54-year-old postmenopausal woman. She was diagnosed in 2010 with an early stage ER/PR positive, HER2 negative ductal carcinoma. She had a lumpectomy and a sentinel lymph node biopsy. She had an oncotype of 14, had adjuvant radiation and tamoxifen for 5 years, and she completed all of this in 2016. So then 8 years later, she was admitted to a local emergency room with pneumonia and found to have a 1 centimeter sternal lesion on a CT. The rest of her staging imaging was normal, and she was asymptomatic. So she had a bone biopsy which showed a grade 1 ductal carcinoma, ER 100%, PR 100%, HER2 negative. Her germline testing was normal. So she has a lot of comorbidities. She has had rheumatoid arthritis for 12 years, managed pretty well with NSAIDs and steroids rarely, some mild baseline fatigue as well. She is very concerned about side effects and insurance copays and really discusses a lot of these social issues with, in the clinic.
Okay. So polling question, what treatment would you recommend? An aromatase inhibitor or the same with the CD4/6 inhibitor? Okay, I think we get the idea.
Very interesting.
Sarah, you want to take us through?
Sure. So this is an interesting case because of her comorbidities and her rheumatoid arthritis. And so the question sort of naturally is begged, can we delay initiation of a CDK4/6 inhibitor in someone who has concerns about comorbidities, concomitant medications, maybe being on immune suppressive therapy and copays and lifestyle considerations? So what I first put here is just a table showing the large clinical trials looking at first-line CDK4/6 inhibitors, and the evidence is very consistent, regardless of the CDK4/6 inhibitor used, that there is a significant improvement of median progression-free survival. And if you look at those hazard ratios, they're quite similar across the board. For Mona Lisa 2 and 7, you have a statistically significant improvement in overall survival, but it's really important to keep in mind these studies did not have crossover built into them. And if you then look at the studies in the second-line setting and later, which I've added onto that table in the last part, you also see significant improvements in survival with abemaciclib and ribociclib in the Monarch 2 and Mona Lisa 3 studies. So could we just, use something easy and simple in the frontline setting and then transition to a CDK4/6 inhibitor when necessary? Now, one study did this very elegantly. It was just published this year, and thank you, Amy, for highlighting that to me, because I had all of the ASCO slides, but Sonia was just published in Nature. And this was a study that was done independently, allowing patients who had no previous therapy for their ER-positive, HER2-negative breast cancer and no visceral crisis to enroll. They had over 1,000 patients. They were stratified based on the type of CDK4/6 inhibitor that was going to be used, and they were randomly assigned 1-to-1 to receive the CDK4/6 inhibitor first with AI, followed by fulvestrant at the time of progression, or starting with an AI alone and switching at the time of progression to a fulvestrant CDK4/6 inhibitor. So the primary endpoint is PFS2, so that second progression event, as a surrogate to see if we're really buying patients more time by doing this up front. The baseline characteristics are shown here, and I think the most important thing to show is that palbociclib by far was the most common selected CDK4/6 inhibitor in this study. So this really isn't, palbociclib so far, and we can argue and debate about why, but it in the metastatic setting has not been shown to improve survival, so some have stated that may be a weakness of this study. Be that as it may, the progression-free survival indeed was lengthened. Again, that hazard ratio of 0.59, so using the CDK4/6 inhibitor in the first line does lengthen that time before your progression event, your first progression event. But for your second progression event and for your overall survival, doing it in the second-line setting is just fine. It doesn't buy you more time to do it in the first-line setting. And so if you look at things like toxicity, as well as quality of life, which they did measure, there were 40% more grade 3/4 adverse events when used in the first line. There was no difference in the FACT-B total score between the study arms. The time extended on therapy was extended by 16 and a half months, and the drug expenditure went up by $200,000 per patient by doing it in the frontline setting. So this data was quite provocative and interesting, and really made a lot of us think about the patient before us and whether or not, especially in a patient like yours who had rheumatoid arthritis, whether we can start with a single agent endocrine therapy. And so I'm going to pass this down to Amy to talk about the patient perspective.
Thank you. So just a couple of non-financial disclosures. I've been living with MBC, hormone receptor positive, for a little over 4 years. And I was on palbociclib plus an AI as my first line for about 3 months. So some specific concerns that Sara already addressed here, fatigue that you get with CDK4/6 inhibitors, which can be pretty intense, but the joint disease as well, thinking about mitigation, like what are ways up front to mitigate pain, because not just with CDK4/6, but with the aromatase inhibitors. When looking at first line, like when I was first diagnosed, I wanted to throw the kitchen sink at MBC. I wasn't as worried about side effects, but I was also living with a pleural effusion. So I was symptomatic, which is different than this patient. There's so much variation, but one thing we all have in common, of course, is that we're scared, as many of you all know firsthand. So communicating the options, communicating the data in as clear a way as possible is paramount. What do we know? How do we know it? What are the risks and benefits, including that being on treatment throughout this disease, of course, is going to be the rule and not the exception, and there will likely be trade-offs. And presenting this in multiple ways as possible. So the communication session yesterday morning, I think was really great. We talked about this, like in person, in a table, in a graphic, like how are you sending this information home for the patient to decide themselves, of course, and for them to talk with their family and their friends. And then some comments on Sonia, specifically, great study. I'm gonna skip some stuff because you covered it so well. I think we need to know who might benefit most from these CDK4/6 inhibitors. Is it people with visceral disease, symptomatic? There was an intriguing result in the Sonia paper looking at lobular breast cancer, and that maybe, this was a post hoc analysis, but maybe they do derive more benefit from a CDK4/6 inhibitor. A couple other things. So cost is real. So that's so important, and thank you for bringing that up. There does seem to be a trend away from copay assistance that I've heard from other patients, that it seems to have started last year in the public sector, but has moved into private insurance, and communication has been quite poor. In fact, people found out that their copay assistance for palbociclib kind of went away, and they found out because they had a copay suddenly. So that's been a problem. There also seems to be a move to decrease and or eliminate copay assistance for those at 4 times the poverty level and move that down to 2 times. So just something to be aware of. And then finally, other options, starting at a lower recommended dose, excited for the CDK4/6 inhibitor dosing knowledge study. And then finally, clinical trials, we need help with this. Ideally, we would love a consult with an expert who can find us a list with lay explanations, within proximity as defined by the patient's needs, and with financial help to travel for childcare. There's barriers to all of this, and I know we're asking for a lot, but if we want to accrue for clinical trials, this is important. There's a couple good online, but not as well as an actual person. And remember, as Stephanie Walker found in the Become Project, if you ask, they will come, and that's super important.
Let me ask a couple of questions that build off some of the ones that are coming in to maybe Sara and Neil. You know, in this particular patient who had sort of limited metastatic disease, one of the issues, you know, there's sort of 3-dimensional chess when we're thinking about targeted therapy partnerships. This patient has arthritis, a single lesion. Would you not consider fulvestrant in this patient? And what would be the implications, particularly when you think about going forward, partner drugs that you may use after progression?
Yeah, I personally think fulvestrant is a great drug. From the patient perspective, I'm always interested in that because some patients really don't like needles, and the injection can be painful, but it also omits the need for them to take a drug that has a lot of arthralgia associated with it, which could complicate somebody who's dealing with rheumatoid arthritis. And not having to take another pill can be a good thing. It does have implications for down the line because we have therapies such as PI3 kinase inhibitors that typically are partnered with fulvestrant. But in this situation, we have also elacestrant and a number of studies looking at oral SERDs, so I wouldn't use that as an excuse to not offer that in this setting. But what about?
Yeah, I think that I think there's also this tension because many of the therapies are combination therapies, and we always have this tension between do you switch one, do you switch the other, do you switch both? And I think many years ago there were many trials that were designed where you're switching both, but I think what we're seeing even from some of the trials presented earlier today is that switching one therapy is it's still sufficient to gain a response in later lines of treatment. So I think this is also where having frank conversations about patients, even when you're treating in the first line, about what would a second line treatment look like, what would a third line treatment look like, and having that very open conversation can explore all of these possibilities.
And one other comment I'd like you to make. This patient had relatively limited disease, so you could make perhaps the argument of radiating the sternal lesion and maybe not getting as aggressive, so to speak, with the systemic therapy. What are your thoughts on that?
Yeah, this is always something that I find challenging in the clinic when, especially in patients who are asymptomatic, they wouldn't have found out about this metastatic lesion had they not gone to the emergency room. And I think our treatment of oligometastatic disease has changed in the last several years given the results of randomized trials. But I think for an individual patient, it's still a reasonable thing to consider with discussion with radiation oncology.
Okay. Dr. Vogel, New York.
Say, but I agree entirely that if the patient was staged thoroughly and there was no other lesion, you would be remiss not to offer stereotactic radiation. It has a 100% response rate. In the sternum, it's essentially without toxicity and is likely to render the patient at least in remission longer just because you won't progress in the sternal lesion anymore. The patient's at exceedingly high risk of systemic relapse. And I would tell the patient that. And I would tell the patient that probably the best therapy for systemic disease is the one we should give her now. But all that is on the table. But someone should talk about radiation.
Agreed. Okay. Okay, we're moving on and going to case 3. And Dr. Hurvitz again.
So this is a 62-year-old woman diagnosed with de novo, ER-positive, PR-negative, HER2-1+ metastatic breast cancer involving bone and lymph nodes, as well as bilateral lungs. She has first-line ribociclib plus AI and is able to experience a partial response for 2 years. Her disease is now progressing with 2 1-centimeter lesions in the liver and new lung metastases. ctDNA is sent, and she has a PIK3CA mutation. She also has type 2 diabetes that's well controlled on metformin. Her HbA1c is 6.9, hypertension on a beta blocker. She's very active and has a good performance status. But she's a primary caregiver for her 11 and 13-year-old grandchildren. She wants to be well enough to keep up with them, and her long-term goal is hoping to see them go to college. So the question is, what treatment do you recommend? Fulvestrant abema, exemestane everolimus, fulvestrant palbo inavolisib, fulvestrant capivasertib, or fulvestrant alpelisib. She has a PIK3CA mutation. It's interesting, I was just thinking as I said this, because we are now required at our institution to put goals of care notes in every 6 months in our chart, and if it doesn't come up, there's a template that you can't close your encounter until you've entered a goals of care note, and that's for stage 1 through 4, which is kind of interesting, and the questions are really, and this is why I knew that this particular patient, her goal was to see them go to college, because when we're doing the busy work of figuring out what treatment to give a patient, sometimes we don't take the time to ask the patient what's important to them. So it's kind of interesting.
Neil, any thought on the distribution here?
Yeah, it's fascinating. I think it just speaks to how quickly this field is moving and how we have new drugs that are entering the clinic. Capivasertib was just approved last November, and already we have large uptake both in the real world as well as in the recommendations of oncologists today.
Okay, Michael, you're up.
Yeah, sorry, thanks again. So yeah, I'm jumping back in. I just wanted to kind of, once again, from a basic research perspective, just wanted to give you an idea of some of the things that are kind of on the forefront of looking at CDK4/6 inhibitor resistance and how we could potentially overcome it with targeting. So as many of you, I'm sure, are aware, a lot of what's been known about CDK4/6 inhibitor resistance really centers around the cell cycle and upstream signaling pathways or crosstalk between them. And this has led to the discovery of many different types of targetable pathways or targetable aspects of overcoming resistance. But what I really wanted to focus on is kind of those emerging kind of avenues, two of which I'll focus on today. So one is immune effects. This is something that's it's kind of bubbling beneath the surface, in my opinion. But I think it's something that, with given better models, in particular using 3D organoid models and cold culture systems, where we can take, our breast cancer organoids and cold culture them with immune populations, really might allow us to kind of better understand this aspect of CDK4/6 inhibitor resistance. I've highlighted a couple of seminal kind of discoveries in this. This is not specific to ER-positive breast cancer, but to cancer overall. But once again, an opportunity here to maybe leverage understanding into therapeutic strategies. And then something that I'm really, really focused on, in particular for my work, is the role of metabolic reprogramming. So as many of you are probably aware, cancer metabolism is really emerging as a really distinct and critical aspect of tumorigenesis and tumor progression. In my case, I'm really focused on its role in drug resistance. And as you can see here, I've just highlighted, these are kind of the hallmarks of cancer metabolism. And a few of which I've starred here are some things that my work focuses on, which looks at CDK4/6 inhibitor resistance, and once again, that role of metabolic reprogramming. And I think, once again, there are avenues here that we can exploit for targeting and developing therapeutic strategies. So for instance, my work focuses on amino acid transporters. And these are obviously on the cell surface, so readily targetable. The one that I'm focused on, SLC7A5, actually has a small molecule inhibitor that's been developed that can target this amino acid transporter, as well as metabolic enzymes that also could be readily targeted. One example of this is gabapentin, which is readily used to mitigate side effects, but it also targets metabolic enzymes. And in this context, there's work that I've shown and some others that this could be leveraged or could be could be targeted to overcome drug resistance. And so I think, really in this context, leveraging those patient-derived organoid models and some of the things that we can do in terms of metabolic reprogramming, which is what I'm focused on. In particular, one or a couple examples that I wanted to bring up was the fact that now we also have in our cell culture model conditions, we have ways to better mimic the in vivo microenvironment. So for instance, we have human plasma-like media that's been developed, which better recapitulates the nutrient availability for ER-positive breast cancer cells. And there's also tumor interstitial fluid, which also is a kind of a different way to think about this. Once again, to mimic or better mimic what is seen in vivo. And combining this with our organoid models, I think we're really at an exciting time in order to identify alternative or novel therapeutic strategies to overcome CDK4/6 inhibitor resistance.
Thank you. So Neil, you want to take us through your thinking about how you would approach this case and what the data is to support that?
Yeah, so thanks. We have a lot of drugs now to target the PI3 kinase pathway. Of course, we've known genomically that this is an important pathway, not only in breast cancer, but in a large number of other cancer types for nearly 30 years. And as a field, of course, we started with mTOR inhibitors that were FDA approved about 12 years ago. It's taken a very, very long time to find PI3 kinase inhibitors that are effective and also well tolerated, not only in individuals but in populations. There's been an enormous emphasis on, or an enormous change in how we specifically target this drug. I wrote PI3K, but here we're really talking about the alpha isoform. It's taken many years to figure out that we have to combine these drugs with endocrine therapy. It turns out that all of these drugs as monotherapy have no efficacy in patients. And it's also taken us a long time to figure out that it's in specifically ER-positive breast cancer and in biomarker-directed populations that we see efficacy signals in large trials. We know that recently, or in 2019, alpelisib was approved with fulvestrant, and just last November, the AKT inhibitor capivasertib was approved, and then just a couple months ago, inavolisib in the first-line setting with palbociclib and fulvestrant. So again, a very fast-moving field, and very exciting that we have many drugs that are approved and also many of these drugs in trials. I think another interesting theme that we are seeing as well, at least in estrogen receptor-positive breast cancer, I think it remains to be seen if this is true in other cancer types, is that the more upstream you are in the pathway, the fewer number of biomarkers there are. And the more downstream in the pathway, there are larger patient populations who benefit. So what do I mean by that? So when we target PI3 kinase, the biomarker of response is PIK3CA mutations. PTEN mutations shown in red here, those are known mechanisms of resistance. When we get to AKT, which is in the middle of the pathway, we have patients with PIK3CA altered breast cancers who respond, but also alterations in PTEN and AKT, which are much rarer. So PIK3CA mutations about 40%, PTEN and AKT 1 to 3%, but still clear signals in the Capitello 291 trial. And then when we get down to mTOR, very, very far down in the pathway, the best data, clinical data available shows that there is no mutation that predicts for sensitivity, that in all comers benefit. So this is a summary of all of the registrational clinical trial data. So I put this up in some ways for historical purposes. Again, I think we've all said that this is a very fast-moving field. The first column I want you to actually see is the prior CDK4/6 inhibitors. So many of these trials were designed and executed before the advent of CDK4/6 inhibitors. And the next slide, I'm going to talk about what the data in patients who've had CDK4/6 inhibitors. But we have, again, 4 approved drugs with different combinations. The progression-free survival improvements are all robust, average hazard ratio of about 0.5. We're often doubling progression-free survival. To Dr. Hurvitz's point, I think that this is a very frank conversation we have to have with patients, that to date, we don't have an inhibitor in this pathway that improves overall survival. We know that with alpelisib, this was not statistically significant. With everolimus, not statistically significant. I think the jury is still out with inavolisib and capivasertib. We're certainly really interested to find out these endpoints, but they're still immature at this point. In terms of adverse events, this is where I think we're starting to see a large diversity in this profile, and this is where individual patient characteristics and comorbidities become very important. So, sorry, I think that I had to abbreviate some of these, but so just to start out with alpelisib, we have over a third of patients with grade 3 or higher hyperglycemia, and the patient population that was investigated had an A1C less than 6.5%. This is very stringent. We have so many patients who don't fit these very, very strict criteria, and we have to make decisions, is this the best drug for them or not? So with the approval of capivasertib, the third row, this drug has a 2% rate of grade 3 or higher hyperglycememia. It has a less stringent A1C cutoff. This patient, I think, had an A1C of 6.9. Thank you, 6.9%. So would have fallen into those criteria. Capivasertib different. It has more rates of diarrhea, more rates of rash, and I think these are things we're seeing now in the real world now that we're giving this drug more often. One small chestnut is that when we think about hyperglycemia, the definitions of this have actually changed in the clinical trial literature. So many years ago, we used a definition that had more to do with the fingerstick glucose number. If it's greater than 250, that was grade 3. Now, many trials, including the trials that tested inavolisib and capivasertib, use a newer definition that's more of a functional definition. It has to do with, do you need insulin or not? That's actually a very important distinction because, as we all know, the world of diabetes management has radically changed in the last 5 years. We are giving a lot more oral therapies, the Ozempics and Mounjaros of the world. And so these are numbers that are sometimes a little hard to, it's a little bit apples and oranges in comparison. I say this because inavolisib, we know, has certainly much lower rates of hyperglycemia. It's 6% with the new definition. The old definition is actually around 13%. Still much lower than alpelisib, but that's, I think, the best head-to-head comparison. Of course, we know that with everolimus in the trials, we had high rates, or 8% grade 3 mucositis, which of course we know can be decreased with dexamethasone mouthwash. So a lot of data here, a lot of, I think the big points, improvements in PFS, no improvements in overall survival to date, diverse AEs that we see, and also diverse management strategies. So what about in patients who've received CDK4/6? So these are the data that we have to date from alpelisib, capivasertib, and this is actually from everolimus. This was a study that was published this year, specifically looking at patients who had received CDK4/6 inhibitors. And in all of these studies, we're seeing, again, a PFS of about 5 to 7 months in the second-line setting. And these are, the numbers that we have to communicate with patients.
Can I ask a question of my panel? I want to know how you're preparing patients, Dan, when you've decided you're going to put them on. They have type 2 diabetes and HbA1c 6.9, little overweight, very busy person. How do you prep them before putting them on Capi or Inavo?
Yeah, I think it's a great question, and I definitely take the teamwork approach, and the team includes the patient. I think part of it is patient education and patient partnership, so that there is clear communication about what's going on with their sugars. I think the other part of the team is that leaning on consultants or partners who may have greater expertise in the fast-moving field of glucose management. As Neil indicated, there's a lot of new agents that, when I was in internal medicine training, didn't even exist. And so I think there's a lot of ways that we can manage an early intervention and early partnership. So I definitely take a sort of a team model to it, with the patient sort of at the center. And I find that it sort of takes away the scariness of it. That I think some of these agents, there was a lot of insecurity about very high glucoses early on. But I think if we're proactive about it and have more experience, then there's the opportunity to add more tools to the tool belt for patients.
Marla, are you using keto diet at all in your patients?
I have not routinely discussed keto diet with my patients, but I do have patients that bring it up in clinic and do like to go through data with them. I also will just add to what Dan was saying in that some of our patients that are on these newer diabetes agents are being followed already by endocrinology, and it's been great to be able to partner with them. And many times patients will discuss with their endocrinologists and with us before making a decision. And also for those patients that develop hyperglycemia while on the drug, getting input and having close contacts, even if patients aren't being seen formally, is quite helpful.
Neil, would you ever put a type 1 diabetic or an insulin-dependent diabetic on a PI3 kinase inhibitor?
So no, I would say no at this point. The reason I paused is that we again, very fast-moving field. We have a new class of drugs, these mutant-selective PI3 kinase inhibitors, which I guess could segue into the next slide. I think this whole field is about, when we talk about efficacy and toxicity, I can't think of a single drug class that exemplifies that tension compared to the PI3 kinase inhibitors as an entire drug class. And we know that PI3 kinase is so important in normal metabolism in human beings, and so any alteration in that pathway can have a lot of side effects. I think that one really creative way that we are seeing now to manage these toxicities is to take some of them off the table, is to have drugs that only inhibit the mutant PI3 kinase that's in cancer cells and not inhibit the wild type unmutated PI3 kinase that's in muscle and fat and liver that contributes to hyperglycemia and other on-target side effects. And so, I think this is exactly to Dan's point, that we have to have these conversations about efficacy and toxicity in the same patient, in the room with the patient, to think about a lot of plan Bs and what if we see this, what if we see that. I think mutant selective inhibitors, there are two that are being presented at this meeting, Relay 2608 and Scorpion 478. These are really interesting drugs. They seem in small numbers of patients to have very little to no hyperglycemia. And so then to your point, I think in the future we're going to be seeing more studies of these drugs with more liberal A1C cutoffs. And I think then we'll be able to answer that question very rigorously.
Before we go back to Amy, I want to ask two quick questions, one to Marla. So if we think back to the scenario I gave Sara a moment ago, the patient it's coming to you for a second opinion. You didn't do this. So the patient got fulvestrant first line, has a PI3 kinase mutation, there's no ESR mutation, and now she comes to you. What are you going to do?
So they have not gotten an aromatase inhibitor yet, is that right?
Or a CDK.
Or a CDK, yeah. I think that's an interesting question. Neil brought up the BILEAVE study, which looked at alpelisib with an aromatase inhibitor and alpelisib and fulvestrant, and at least we do have safety data and efficacy data with an AI and alpelisib. And at that point, I do tend to discuss with patients. Most of my patients in that scenario probably would elect for CDK4/6 and an aromatase inhibitor, but I think it would be worthwhile to talk through the risks and benefits of a targeted approach with.
And if the patient had gotten a CDK, but had fulvestrant with it, and now comes with this, would you revisit fulvestrant again?
Yeah, it's a good question. With no ESR1 mutation, if they've never had an AI and they were willing to try it in terms of the bone pain, I think it would be reasonable to try an aromatase inhibitor and a PIK3CA inhibitor. But from a patient perspective, if they were uncomfortable with the prospect of the joint pains, I think it would be reasonable to continue fulvestrant.
And Neil, on the question of CAPI, the P10, the fraction of patients who had P10 alterations was relatively small. It's not that common. Is it any P10 alteration or is it just deletions? What is it that make patients eligible to get that drug?
Yeah, so in the companion diagnostics for P10, it's a combination, it's generally mutations. And one thing that's interesting is a lot of these companion diagnostic reports are now reporting, is this a functional mutation or a non-functional mutation, similar to the analogies of variants of unknown significance. And so this is an area where some of these tumor suppressor genes like P10, if a patient has an unusual mutation, it's really important to talk with your oncologist, because there are some mutations that we have some data that these are true loss of function mutations, and others where we're not so sure.
Okay. And then coming back to Amy to give the patient perspective.
All right. So I appreciated, Sara, your talk about goals of care. And I think anytime, we're looking at a switch in therapy, that is an important conversation to have. And of course, this is a decision point where there are lots of options, it sounds like. And so, comparisons of quality of life are very important. And if we don't have data on, what's the best order, what's the best efficacy, how do we make these decisions? As Dan pointed out, shared decision-making with the patient at the center, with teams of doctors is really important. But it's also harder for patients as there is a lot to digest. There's a lot to understand, including genomic testing, which is not something that, everybody is going to understand, or most people are even going to understand. So to make the best decisions, I think we need education for patients. So one example, of course, there's an education series for MBC patients and caregivers we created with Project Life, and Dr. Maya Roberson is going to present a poster tomorrow, so that was a little bit of a self-serving thing there, but check that out. Additionally, Dan and colleagues, so you guys have worked on this short genomic testing video, which is awesome, but it takes time, it takes resources, and we have to be creative in this, but I think it's absolutely necessary so that patients can make informed decisions, because it's not shared decision-making if we're not actually informed. So I really liked, Neil, your side effect profile, super helpful. But also keeping in mind grade 2 adverse events, so like a grade 1 or a grade 2 diarrhea is still pretty nasty and affects quality of life. So all oral, so all these are oral, so out of pocket, what are the cost differences we're looking at here? We're dealing with insurance, we're dealing with pharmacy, we're dealing with pharmacy benefit managers. Personally, I was off everolimus for 2 weeks when I switched private insurances because there's no overall survival benefit for everolimus, and they told me I did not need it, even though I had been stable for a year and a half on everolimus plus fulvestrant. So we had to fight really hard for that, to get that back on a drug that was clearly working for me. So that's another thing to keep in mind, that this may set up fights there. So another thing, like while overall survival data is gold, there is obviously benefit in certain situations, drugs to progression-free survival. So I was stable, I didn't have a pleural infusion, I was not short of breath, and that was obviously, that quality of life was so much better. Side effect mitigation, of course, up front, like you mentioned, the Swish trial for mouth sores, mucositis, hugely important. I think we need more of those upfront trials if you have a lot of people you know are going to experience this. That's a dexamethasone mouthwash, super easy, and prevents those really, like, that side effect that really can affect quality of life. Diarrhea for capivasertib, that's tough. Definitely need a better drug than Imodium, because we don't want to tip over into constipation. We don't want to have other side effects by the drugs that we are taking for the side effects. I know you all are aware of that, but that would be great. And I think Dan really covered this well with the hyperglycemia, and I heard this from patients too. Having an endocrinologist on board initially, incredibly important. But again, this adds more time, appointments, travel, blood monitoring for glucose. So those are other things to keep in mind. And of course, as everybody here is up here has said, keeping the patient in mind, providing information that they can take to their families, that they can take to their friends, in as many ways as possible, because these are, anytime there's progression, there's trauma, really. Oh, and of course, we need biomarkers for efficacy and side effects. I think I've had that on every slide, so, and then approved dose reductions when needed.
Thank you. I think we're going to pass on to Dan for the next case.
Great, thanks so much. So this was a 58-year-old postmenopausal woman who was diagnosed in 2022 with de novo metastatic estrogen receptor positive, progesterone receptor positive, HER2 low, ductal carcinoma. It was metastatic to bone, primarily in the spine, and she did have pain on presentation. So the patient, we did have some shared decision-making conversations, and this sort of goes back to the earlier discussion after Sonia, and she really did not want to start on a CDK4/6 inhibitor, and she also had strong preferences that she wanted an oral medication. So she did go forward with letrozole alone, and I think one of the things we talked about at the time is before there was CDK4/6 inhibitors, this was an effective treatment for many patients. So she was on letrozole alone for 13 months and then progressed, and she enrolled in a study and received a PET CT scan that showed new uptake in a couple of bony areas, and obtained liquid biopsy, which showed multiple ESR1 mutations as well as a PI3 kinase E542K alteration. And I mentioned her strong preference for oral medication, and so that may influence your thoughts as we think about what treatment you might recommend. Okay, so we'll go through these. So would you recommend fulvestrant plus CDK4/6 inhibitor, elacestrant, fulvestrant plus alpelisib or capivasertib with the PI3 kinase mutation, fulvestrant, inavolisib plus palbociclib, or capecitabine?
Interesting.
Yeah. So looks like it's steadying out with most leaning towards recommending elacestrant, and a second group, fulvestrant plus CDK4/6 inhibitor. So pass it over to Marla.
Thanks, Dan. So there were a number of good options that it sounds like you discussed with this patient, and I think initially my approach was taking her perspective of feeling strongly that she wanted an oral medication, and so my initial thought was the same as most of the people in this room, to consider elacestrant for her. So elacestrant is an oral approved selective estrogen receptor degrader. This was studied in the phase 3 EMERALD study. I will call out here that patients in this study had received prior CDK4/6 inhibitor. So keeping that in mind for this patient that had not received prior CDK4/6 inhibitor, and what that might mean for her treatment on elacestrant if that is pursued. And in EMERALD, when they looked at elacestrant in patients specifically with ESR1 mutation, as this patient has, it was presented by Dr. Bardia and colleagues at this conference that elacestrant was associated with a 45% reduction in the risk of a progression-free survival event in patients specifically with ESR1 mutation. And I'm not sure about others on this panel. Whenever I am thinking about prescribing elacestrant, I do consider the duration of prior CDK4/6 inhibitor in the metastatic setting to really think about the probability that this patient remains endocrine sensitive and has endocrine sensitive disease. So we don't quite have that in this patient to help make that decision. We do know that they were on letrozole, and it sounds like did quite well on that for some period of time, but what we know from the data from EMERALD, presented by Dr. Kaklamani and colleagues also at San Antonio, is that patients that have been on CDK4/6 inhibitor for longer prior to their participation on EMERALD, they did seem to have improved progression-free survival compared to those patients that were on this for a short amount of time. And then specifically looking at that here, you can see in the curves specifically those with elacestrant versus standard of care by time on prior CDK4/6 inhibitor. And so we talked about this briefly earlier. You know, this patient has both a PIK3CA and an ESR1 mutation. And I think this is a growing area in terms of questions, what to do when patients have co-mutation. This patient has multiple ESR1 mutations. Yes, she has a PIK3CA mutation. I think she relayed her strong preference for oral medications. Would it be reasonable to try alpelisib and letrozole for her, to try PIK3CA inhibition and an oral aromatase inhibitor? And this trial from Dr. Turner looked at alpelisib and fulvestrant as well as alpelisib and letrozole, and they even broke it down with and without ESR1 mutations. They found in particular that those with ESR1 mutations did tend to have a shorter median progression-free survival than those without ESR1 mutations. But really with this data, we could consider a fully oral option here.
Pause you here for a moment because I have questions about this. This patient was really interesting, Dan, having multiple mutations. And so I'm curious how everyone in the panel would address the decision of therapy. And I'm going to start with you, Neil, because here she's got a targetable PIK3CA and multiple ESR1, and certainly the patient input and strong desire for all oral therapy has to play in. How would you approach that?
Yeah, I think it is interesting that she had letrozole initially, and I would really think about a CDK4/6 inhibitor in the second line setting. It's interesting that the percentages, because I think something like 80% of the audience members said elacestrant, which is interesting to me because there are so many options and there is a lot of equipoise. None of these have been compared head to head. I also think about elacestrant in the conversation that it's one medication. I think that all of these, right, are combinations, and I do think that there are many patients who really like the idea of being on just a single medication. So those are some of the things that I think about. In terms of the polyclonality of the ESR1, I think it's really hard to know what that means. I do think that the more data that we have on oral SERDs, especially past meeting phase 3 randomized controlled trials as shown by imlunestrant earlier today, I think we're going to get more data about that.
And Bill, what would you do? She's had single agent AI. She's never seen CDK4/6 inhibitor, as Neil says, but she doesn't want an injection and has an ESR1 mutation. We did see the imlunestrant abemaciclib data today in the EMBER-3, but that's imlunestrant's not available yet. So how would you manage this?
Well, I try to figure out a way of giving her a CD4/6 inhibitor. I mean, we know it's not going to work as monotherapy. You can combine it with other endocrine agents, and I would try and do that. And if it's a line in the sand about fulvestrant, so be it. Then I try and either give her a different AI or even tamoxifen.
Okay. Dan, any other thoughts on this and how you approached it?
Yeah, so, I think as Neil said, there's a lot of options in this setting, and we don't have head-to-head studies, and so I definitely took a very heavy shared decision-making approach with this patient and sort of laid out, these are the options, this is what the data that we have, and did my best to partner with her to find the right path for her.
Okay, great. Excellent. Marla, any update on?
I think I would also add that there certainly are trials looking at combination therapies with oral SERDs. We saw EMBER-3 today. And then also there are additional updates with studies looking at elacestrant and combination with CDK4/6 inhibitor. So if I had a choice, I probably would have put this patient on a trial. But certainly it is extremely important to also understand what we would do in the standard of care setting.
So one question that came in that builds on another one that was previously asked is, since half of the U.S. is on Ozempic or something else like it, is there any concern, this patient who has a line in the sand wants oral medications, is there any theoretical concern about absorption?
And I think, just to clarify, is this patient on an oral anti-hyperglycemic medication? Or? No. Okay. So I do think that with any drug, certainly, there can be problems with oral absorption. It sounds like she's done particularly well on letrozole and did well with oral absorption with that. So I would hope that she would similarly do well.
I think this, again, is an area we don't have a lot of information on.
Yeah.
That could actually be an interesting research question using ctDNA, for instance.
Yeah.
That's a good point.
Okay.
So the patient initiated elacestrant, and she was on therapy for 7 months with that oral monotherapy. And I guess then we've crossed out option D. So then what treatment would you recommend now? Again, in this space, we still have a lot of potential options. So Marla, if you want to click through, I think the polling will open.
Again. All right. So it seems like the majority would choose fulvestrant and CDK4/6 inhibitor.
Okay, so Marla. Yeah. Next case, final case.
All right. So it looks like this is the last update.
Yeah, so the patient received fulvestrant and ribociclib for 3 months and then developed new liver metastases, and you can click again. And so at that point, the patient transitioned to capecitabine and did have a clinical and radiographic response, and she remains on capecitabine now over a year later.
Great.
All right.
All right, so this is a case of a 64-year-old postmenopausal woman with ER-positive metastatic breast cancer. She was initially diagnosed in 2011 with ER-positive, PR-positive, HER2-low, a 2.1 centimeter invasive ductal carcinoma. She had a lumpectomy, sentinel lymph node biopsy, and had a T2 N1A. Had an oncotype of 16. She received adjuvant radiation as well as adjuvant letrozole for 7 years. And then 10 years after her initial diagnosis in 2021, she developed a new persistent cough. At that time, a PET CT scan showed quite large 31 millimeter and 12 millimeter right upper lobe lung lesions and diffuse mixed lytic sclerotic osseous metastases. She did have a lung biopsy. It showed ER positive, PR negative, HER2 low adenocarcinoma, which was consistent with breast origin. And she received exemestane and abemaciclib for 8 months. At that point, had progressive lung disease on PET CT scan. She did have a liquid biopsy after that with next-generation sequencing that did not reveal any actionable alterations. Subsequently, she went on fulvestrant and everolimus for 6 months, at which point she had progression in the liver.
So, polling question, what treatment would you recommend? Single-agent Taxol, sacituzumab govitecan, CAPE, TDXD, trastuzumab deruxtecan, or Gemcarbo?
Okay, it looks like trastuzumab deruxtecan is the strong winner, with capecitabine coming up second, but nowhere near where it needs to be to beat it. So I think this brings up a really clinically relevant question in the clinic. When do we pivot to an ADC? And in the situation of hormone receptor positive, HER2 negative breast cancer, where some patients really want to remain on oral therapy as long as possible, capecitabine, I think, is the biggest question of when do we improve our patients' long-term outcome by going straight to TDXD, or can we buy them some time on capecitabine, and how do we select patients for this decision? So what I've done is summarized in this table here all the antibody drug conjugates in metastatic hormone receptor positive breast cancer that have been studied in a phase 3 clinical trial. The Destiny Breast 04 was a study to first come out looking at TDXD versus treatment of physician's choice, and it allowed patients with both hormone receptor positive and triple negative breast cancer and 1 to 2 prior lines of chemotherapy. Patients had to have exhausted endocrine therapy, and it demonstrated very significant improvement in progression-free survival with a hazard ratio of 0.37, as well as overall survival, and quickly became, within weeks, the standard of care in patients who'd received systemic chemotherapy for hormone receptor positive HER2 low breast cancer. In Destiny Breast 06, I'll talk about that in a moment, but this was challenging whether we could go in the frontline setting. So do we omit that capecitabine or that first-line systemic chemo after exhausting therapy? Is there benefit there? So I'll skip that for a minute. TROPICS-02 was sacituzumab govitecan, the TROP2 targeted ADC with a topoisomerase 1 inhibitor payload compared to treatment of physician's choice. And this was even more heavily pretreated patients, 2 to 4 prior systemic chemotherapies, so you can't really compare TROPICS-2 to Destiny Breast. PFS was significantly improved, but around 5 weeks. OS was also improved on the order of about 3 months. And then the Tropion Breast 01 was the most recently disclosed data of datopotamab deruxtecan, again, TROP2 targeted therapy using the deruxtecan payload. And similar to Destiny Breast 04, 1 to 2 prior lines of systemic chemotherapy. The hazard ratio looked good, 0.63 in favor of datopotamab. And this was all hormone receptor positive, so it didn't have a component of triple negative, and it wasn't for HER2 low, so it was just hormone receptor positive. So these are the studies that we have available. Most recently, we've received data from the Destiny Breast 06 phase 3 randomized trial looking at TDXD versus TPC. Now, the difference between DB06, this study, and DB04 is 2 things. First of all, it's frontline use of chemotherapy, so patients have had endocrine therapy but never have had chemo in the metastatic setting. And the second thing is there is a cohort of patients who had ultra low expression of HER2, so the HER2 IHC could be 0, but the pathologist had to look at it and see that there was some level of expression of HER2, just not at that 10% level to be a 1+. PFS by BICR was the primary endpoint in the HER2 low. The analysis showed that TDXD was associated with a 5-month improvement in progression-free survival, highly statistically significant, hazard ratio of 0.62, compared to standard of care chemo. And I should mention the standard of care chemo is capecitabine or taxane. And so it wasn't all capecitabine, but it was limited to those 2 chemotypes. And here's the forest plot showing outcomes for PFS based on these various subgroups, looking based on the choice of chemotherapy toward the bottom there, capecitabine and taxanes. They both seem to, benefit with TDXD compared to the treatment of physician's choice, regardless of what choice of chemo was used. And then the objective response rate, in my opinion, was the most stunning result here, and I've been using in my practice to help determine where I'll use TDXD in that frontline setting, because the confirmed objective response rate was almost 60% with TDXD. And for an ER-positive, exclusively ER-positive HER2-negative breast cancer, and that's like historical data there. So for a patient who really needs to achieve a response due to symptomatic disease burden or threatening organ function, I think these data are very helpful. Duration of response was also quite good in the TDXD arm. So how do I put all this data together in terms of determining in this particular patient who's chemo naive and has HER2 low expression, do we do TDXD or do we do capecitabine? And so Amy will give the patient perspective, but from my point of view, I think we need to look at factors such as clinical characteristics, the pace of disease, and the need to obtain a response. The PFS is substantially better, so I think we have to share that with patients. We don't yet have the data breaking down how patients who received capecitabine did compared to the taxanes, compared to TDXD. That wasn't a randomization factor, but I think is important information. And we don't have survival benefit yet, and there was no crossover built in this. So we aren't able to extrapolate from this study and say getting capecitabine first harms long-term survival, even if the survival from this study is positive, unless we know everybody goes on to get TDXD as the next line. So that's a limitation. There were 3 deaths in this study due to ILD. So this remains a significant problem. We have to be monitoring our patients closely with imaging and symptom checks as well. And I think this is a critical area for our patient, physician, and caregiver discussions in terms of deciding how to or when to pull the trigger and use an ADC.
Before we go to Amy, I just want to ask Dan a question. So in this case, if you think back to the duration of time on each of the endocrine interventions, aside from the adjuvant letrozole, it was modest. And it seemed to get more abbreviated with the passage of time. So with Sarah's discussion about how she's deciding between TDXD and CAPE or something else, does that influence you at all about your decision making?
It's a great question, and I do think that it does. I think there is a group within the field that feels like moving sort of the best option first, may be the best approach. And I think with this patient, with the potential, acceleration of disease, as you said, less than 12 months for both of those lines of therapy, it is certainly a little bit concerning. And then burden of disease, there are certainly the risks and benefits that Dr. Hurvitz really outlined nicely, but I think this is a patient, especially with the IHC 2+, as we saw in the forest plots, and we know from clinical experience, those patients tend to respond more frequently and frankly better, that this patient is likely to respond to TDXD, and so I probably would sort of lean towards that, but discuss both options with the patient, yeah.
Okay, Amy?
So I'm trying to remember why I put SG in here, actually, since it really wasn't part of the discussion, but I think it was because it was another ADC. I want to acknowledge that moving from a hormone receptor positive, as a hormone receptor positive person, moving from endocrine therapy to chemotherapy of any type is a really scary step from a side effect quality of life standpoint, and also from a just, dealing with the reality of the disease and the progression of the disease. I really appreciated the discussion of how quickly the disease is moving as playing a role in that. And communicating that, I think, to patients is really important, because I don't think we always know, that what, ER positive can sometimes be described as an indolent disease, which I hate that term. But, and it can go from growing slowly to growing really quickly, and we're not always aware of that. So I really appreciated that point. I think it's also an important time, based on Wednesday morning's kind of conversation again, on communication, to bring up prognosis with patients, because it is a really big step. So those are kind of side notes, and let's get down to the actual comparisons. I'm one who likes tables and charts, which is why there's a table and chart here. We need comparisons and side effects, quality of life, data on efficacy. And Dr. Hurvitz, thank you so much. I should have used, I think, in the capecitabine, Eric, the comparison for DB06 would have been a little bit better, but kind of worked with what I had. So even if they are imperfect comparisons, so, we hear a lot here, and I absolutely appreciated that, we can't compare these because they haven't been compared head to head, but we have to make decisions today or in the next week with imperfect data, and sharing that imperfect data, I think, is important in using what we have. And of course, including the clinical expertise of our oncologists, which we appreciate. I've done some of these before, including SG. I did one with capecitabine, which, full disclosure, I did go on capecitabine after endocrine therapy. So looking at a comparison, so there's a big, capecitabine's oral. There is no time to travel. There is no time in chair. So TDXD is day 1 of a 3-week cycle. So I only travel a half an hour each way, but some people travel 3 hours. And that's a really big deal, especially if you're going in maybe for fluids to deal with side effects, and you're adding another day. And then if you look at SG, of course, you've added another day in that 3-week cycle. And that tends to be a longer infusion, a longer time. I'm on SG and I'm in the chair. I'm almost 6 hours sometimes. I'm there at the infusion center. So I think that's an important thing to keep in mind. So again, imperfect comparisons on PFS and OS. We need efficacy biomarkers, right? It would be great to know, is Enhertu going to work? Or is it 50% going to work? Like, that's really helpful, obviously. Side effect profiles, they're so different between these, that having that discussion and laying out what you're looking at is really important. Using like kind of grade 3 AEs as severity, capecitabine versus TDXD, very different. So your quality of life is likely to be different. And then if you add an SG, 74% grade 3 AEs. And thank you for bringing up the ILD, the 3 deaths. Like, that's huge, obviously. And many oncologists are, but not every oncologist is really good at that. I remember actually educating my dad's oncologist about ILD when he went on to his TDXD. So really important. I'm getting off topic. So side effect profiles are really important. I think, we do have side effect biomarkers for capecitabine, this DPYD. I was offered DPYD testing the day before I went on capecitabine when it had been ordered for 3 weeks. I probably would have done it if I, didn't want to get started on that. I think that's important. Of course, we have for SG, but not for TDXD. If we have it, let's use it. If we know that people with these genetic variants are going to have more side effects that could be, in some cases deadly, let's make sure we use those. Finally, again, if cancer burden, cancer symptoms are really important to keep in mind. Dose reductions, of course, I love the X77 trial for capecitabine. That is really important. Lower doses may be as effective and have fewer and less side effects. I'm hoping you were able to catch the great session yesterday on dosing. Really striking to me were some of the real-world studies that I have on there for SG, where up to 58% of people were starting on a lower dose. There's one study showing 18% of people are starting on a lower dose of SG, which to me makes me think that we're not doing that right. Finally, So this obviously, lower doses needs to be an option, needs to be discussed, and I'm going to throw out the patient-centered dosing initiative as a survey coming out on ADC dosing for and side effects for patients, and later we're gonna have a generalized dosing study. And then I wanna just end with ADCs are amazing drugs. Like the efficacy you pointed out, like they're amazing and they're going to prolong life. However, they can have people tolerate it and work through it, and it's great to just really, the quality of life is almost nada. So I think that's really important. It's almost not there. So finally, shared decision-making, transparency, and communication are paramount. Moving things back in treatment lines like we're talking about here could profoundly affect the time someone has good quality of life. And then finally, I have the clinical, I meant to point that out, usually clinical trials, of course, should be an option.
Great, thank you. So a couple questions. We're almost at the end here. Neil, this table and what's emerging out of clinical trials again gets back to the sequencing question. So what can you tell us about sequencing ADCs? We have limited information, admittedly, but
Yeah, this gets analogizes as well as, when you have multiple options and multiple biomarkers. Certainly this is a question that cooperative groups are taking on and trying to sequence, for instance, patients who could get sacituzumab or TDXD. Is it better to get one than the other, and vice versa? So these are questions that are being formally tested. I think your table, Amy, is just really evocative, and even integrating the burden, the medicalization to a patient. I think that when you have these discussions, like you just said about the day 8 of SASE, and that's 2 treatments in 3 weeks versus 1 treatment, these are all very real aspects that shape the sequencing. I will say that in general for ER-positive metastatic breast cancer, I would reach to TDXD before sacituzumab, just given the clinical trial design and the primary endpoints and the efficacy benefit. Whereas in patients with triple-negative breast cancer, I reach to sacituzumab first before TDXD. I think that's just based on the clinical trial design, but of course there are patients where I would do the opposite based on some of these other factors.
okay, lightning round, quick questions. Marla, PET scans over everything else, or do you have a preference for imaging studies?
Thank you. I actually asked some of my patients this recently, and most of them have a preference for a PET scan, as it's one scan instead of CT, chest, abdomen, pelvis, and separate from the bone scan. So if it is covered, I do recommend.
Yeah, any pushback on some
Lots of
pushback is you
pushback.
get
Yeah.
there's so many PET scans.
Exactly.
That's problematic. And Dan, back to allele frequency. Can you just sort of address, it's a little bit off topic from this case, but back to, ESR PI3 kinase, are you looking at allele fraction in any way to make a decision about what therapy you choose?
Yeah, so thinking about allele fraction in liquid biopsy, I do take the full picture. I think as discussed in the ctDNA session, results can be difficult to interpret if there's a low tumor fraction, there's a low amount of ctDNA, you may not get a full picture. And then looking at the allele fraction, obviously if you see a higher, then a greater proportion of the reads have that variant. And I think that can influence some of the decisions. Nothing is an all or none, especially because we have zero data to suggest that a low allele fraction is associated with a suboptimal response to a targeted therapy, because that can be influenced by a lot of factors. But I think on the flip side that, if you see a high allele fraction, then that that's present in at least a substantial proportion of the available cells.
Okay, great. Well, we've reached the end of our time, and I want to thank the audience for being engaged and the panelists for their full participation as well. Have a good rest of the meeting.